Okay. Good afternoon, everyone. I first would like to thank Dr. Muhammad Nasrallah and all organizing committee. And actually, I have to thank three persons by name. The first of which, Dr. Miguel Nahas, who gave me a very good opportunity I didn't dream of. And I have a comment for someone of our colleague for a statement said yesterday about being of Ministry of Health. It is not a shame at all. You should be proud of yourself. You should be proud of being a nephrologist. You should be proud you want to learn and you go to learn. Sure, Dr. Muhammad Nasrallah helped me a lot, and I can speak about that. So first of all, just let me see a show of hand. Who know the meaning of this slide? Governance and audit program in nephrology. Okay, just 2 or 3, and 2 of them we speak about yesterday. So it is a little bit difficult, and because we are not aware about this in our country, which is very silly actually, to practice medicine without knowing our aim. So first, I'd like to start, what is medicine? Medicine is the art and science of healing as practiced by physicians and similar professionals, and encompasses all sciences related to it. It is applied science or practice of diagnosis, treatment, and prevention of disease. There are 10 golden rules of good medical practice that were set very long ago. Number 1, practice with kindness, ethics, and honesty. Upgrade professional knowledge and clinical skills. Maintain good patient records, and maintain good working relationship with colleagues. Be conscious of the cost of health care. Avoid publicity, self-promotion, and abuse of positions. Maintain good communication with patient and relatives. Maintain doctor-patient confidentiality. Allow second opinion and referral to colleagues. Be a partner in promoting global health. These are the 10 golden rules in medicine we should keep in mind while practicing our job. The quality improvement movement is affecting our practice in many ways. Our reputation, earning, and credentialing are beginning to depend on it. This patient is reading a newspaper. There is an article about saying if hospital flying if hospital admission equals flying, there is 17 crashes a day. And he would trust a pilot to treat him, to make him his surgery instead of his doctor. Though we were not taught quality improvement in medical school, the well-being of and lives of our patients we care for every day depends on quality improvement. Our agenda today, what is quality, why it is important, can we measure it, and how we do we achieve quality, good quality. First, what is quality? What our patient needs from us is the compassionate care, uncompromising service, and clinical excellence. He needs care and service, good service, and at the same time with professionalism. Everyone deserves quality health care. You can feel that, you can make sure you get the best health care when you are sick or hurt. This is the only time you feel what your patient feels. The Institute of Medicine has defined quality as the extent to which health service increase the likelihood of desired health outcome and are consistent with the current professional knowledge, which is termed evidence-based medicine. This is what our patient needs from us: good performance, more security, without defects, easy to use, and adaptable to my specific need as a patient. It is the quality of our work which will please God and not the quantity. Healthcare quality improvement is the body of knowledge, attitudes, and the skills necessary to efficiently improve or influence and continuously improve multiple elements of care delivery in medical practice. The Institute of Medicine has proposed 6 specific aims for quality improvement, which are to be safe. It is not proposed to introduce a central line for a patient to save his life and he die. You should be safe. It should be effective, whether clinically effective or cost effective. It should be patient-centered, which is really patient-centered, which is a really neglected point in our country. You should provide respectful, responsive, and individualized care. You should trust your patient mentality. There is nothing called ignorant or illiterate patient. He is competent one, and he has to take share in his decision making. but it is our fault not to deliver the old data to our patient and test how much he gets from this data and how can he interpret, and so how is able he to take the decision, good decision. Timely, reducing waits and harmful delays in care. It should be efficient, avoid waste of equipment, supplies, ID, and energy. It should be equitable, providing equal care regardless of personal characteristics, gender, ethnicity, geographical location, and socioeconomic status. What is the GAP, or Governance and Auditing Program? Actually, I learned about GAP from Viola, and thanks to Dr. Megid. GAP is the clinical audit and systematic appraisal, a systematic and critical analysis of quality of clinical care. It is simply to say that you should evaluate your work and see how much it is achieving relative to a standard work and trying to reach this standard. Clinical governance means improving standards. Audit, it is the attempt to improve quality of medical care by measuring the performance in relation to desired standard by improving this performance. To be less formal, it is taking note of what we do, learning from it, changing it if necessary, with the aim of improving care. There is an alternative acronym, which is PDSA, Plan, Do, Study, and Act. Why we do audit? We do audit mainly to improve ourselves, to improve our clinical judgment, and improve our practice, improve our knowledge, benefit our patient, make use of resources, stimulate research, enhance professionalism, and efficient use of resources, aid continuing education, and aid to administration. Quality actually means money. It needs money. But it is easy. It is all about improving patient care. It should be seen as a part of day-to-day practice. Developing a critical eye on what we are doing, trying to improve things all the time. This is the audit cycle. It starts by identifying the problem or issue, then set the criteria or standard, observe practical and data collection, compare performance with criteria and standard, and implement a change. To be simple. Thus, I will give an example of what already done. As a part of audit, it is not planned to be audit in Ahmed Maher Hospital. In the last ESNT course, to those we attend, there was a presentation from one of our colleagues who presented his thesis work. He said that they tested the quality, the measurement of adequacy of dialysis in their unit. They found that it is 0.6, which is too low. So he identified a problem or an issue. He wanted to improve the adequacy of dialysis. So then what he did, he looked for a standard. Standard we get from the guidelines, from the papers, from discussion, as we will see with professors, whatever, set a standard. Then what he do, he observed what happened in his unit, in his own unit. He started to look for the cause of the problem. Is it something related to the equipment, the filter he used, the pump speed, the method of introduction of needles, the maybe something related to the shunt itself, or the surgeon who did the shunt, he made a short access or whatever. And then he found the main problem is that most of the patients with bad quality of dialysis, the main problem was the bad introduction site of the needles. So he stopped his search at this point. He should complete the circle to do an audit. He should compare the performance with the criteria and the standard, okay, to see how much he is far from the standard, then implement a change. Why there is a problem in the introduction of needles? Is it related to the patient? He doesn't want to change the introduction site? Is it easier for the nurse? Is it a problem with the surgeon who does the surgery, making the venous line short? So this is simply what happened in audit. We should do what we should see what is happening, compare that with what should be happening, and then do a change and re-evaluate this change. Changes must be practical. How are we actually going to make the changes? Simply saying we have got to be better will not result in a change. You need to think through in detail. what needs to be done, who is going to do it, when and how. If you get very low results, you may consider, if, for example, I get 20% of what I'm planned to target, I should reset the target, but I should have an explanation why I did that. Auditing may be an internal audit or external audit. Internal audit means I have the ability to criticize my own work, to see where is the critical, the chronic errors, and pick them, not for the aim of accusing or attacking others, no, but for aim of improving our work. No. Ah, sorry. I'm sorry. Okay. Then we come to the first item of the audit. What are we going to change? There are numerous classifications of changes that we can do, but simple one is that we can start by the structure, the availability, organization of resources, or the personnel. I may need to raise the professionalism or the educational level of the staff. I may have to upgrade the machine. I may have to improve the use of antibiotic or whatever. The process, the activity undertaken, that is what is done with the service resources. Well, outcome, the effect of activity on the health and well-being of the service user, that is changes for the individual, which can be attributed to clinical intervention they receive. To make a change, you should be simple and easy. Don't sophisticate the matter. It is easy. Before you start, you should consider the time. Big audit can eat up time and already in an already busy schedule. So keep it simple and small. You should focus on a small problem and try to solve, then make another one. Look at one or two criteria. Don't make a lot of targets at the same time. Engage the whole team. Otherwise, it will be difficult. It is a team ready, enthusiasm, wanting to improve. You should test your team and have a good team and can lead this team. When you start, delegate and share the workload, involve others, make life easier. You can use computer now, you can use database, sheets, whatever. Use protocol standard already laid by others. You don't have to reinvent the cycle, the wheel, sorry. Everything is already available. You just want to make use of. Be careful of data collection. Choose topics which does not entail too much data collection to the extent it becomes exhaustive and subsequent loss of enthusiasm. Some idea about the structure. What's meant by structure? Facilities being provided, for example, waiting time. Some patient, I may improve the quality of care by improving the waiting time of the patient, the availability of the staff, record keeping. All patients' records should have a summary card or equipment. If I did improvement in any of these areas, I did a change. Process. What was done to the patient? For example, referral. Many times we have problem with referral from department to department or with dealing with a patient. A patient may be lost between departments. Prescription, investigation, assessment of fistula care and catheter lock prophylaxis is an example. The outcome, which is the result for the patient. For example, patient satisfaction. This may be done through questionnaire, improving dialysis quality, optimizing anemia management, minimizing transfusion, preventing CKD and BD. All of that could be targets for the audit. Audit could include also high-risk practice, significant event audits, as the hepatitis B vaccination, hemodialysis patient or other. It is all about idea. You have, I'm sure many of you have many ideas to improve the quality of service he provides. Choosing topic again, condition has an important impact on health or of great local concern, as serious consequences otherwise. Condition affect large number of people. Choose something that is really interests you, so you will be motivated to continue. And you should consider the team effect, the feeling towards that topic. Are they interested too? There is no point to audit something you think it is already good. The second point in practice, in practicing audit, is to set standards. An audit standard is a minimum level of acceptable performance for the criteria. Make sure the standard directly related to the criteria. Also should include suitable time frame, which is very important in the standard. We were talking yesterday about the adequate and the good. No. In medicine, we should talk about quality, the best. It is a patient, it's a human being. How to set standard? Looking for national guideline, literature, journals, textbooks, local guidelines, discussion with consultant, discussion with trainer and partners. The key point بتاعتنا انه standards set should be realistic and attainable. We may change the standard or the goal, but you have to justify. Some criteria are so important that they need 100% standard. We should achieve 100% standard, but sometimes it is difficult to achieve. Your standard need to follow on directly from your criterion. For example, patient on dialysis should have regular check of PTH every 3 months. So I should achieve at least 90% of this target in my patient. Preparation planning, it must show evidence of teamwork, otherwise you will fail. Data collection, you can collect information from computer registers, review of contents of medical records, questionnaire, patient, staff, and colleagues, data collection sheets. Be careful of data collection. Choose a topic which does not entail too much data. الناس ما تزهقش وانت ما تزهقش. To the extent it becomes exhaustive with subsequent loss of enthusiasm. Only collect essential information. Use computers to make it easy. Use other staff and delegate. Don't do all the work yourself. And set a deadline, which is very important. Okay. Collect result, analyze the result, summarize the result, present result to the team, simple arithmetic calculation, and use percentage. After that, you will see how much you achieve from the target and re-evaluate yourself. To sum up, you have to choose topic, agree to the standard, observe current practice, assess conformity to standards, intervene to promote changes, and observe practice again, re-evaluate yourself. This is actually a practical experience in a unit that I'm proud to work at. It is a charity work unit, dialysis unit. And this actually the third one which I owe much, and I have to thank despite he's not here, which is Dr. Ahmed Fathi al-Qurei, which support me a lot actually. When we started this unit, we have certain rules. We have 4 machines, Gambro 95. We set rules. We sit with the nurses and set these rules. Rule number 1, we had just that choice to be doctors and nurses, but the patient didn't have this choice to be so. So you have to consider that all the time, whatever stresses we are facing. Rule number 2, patient safety is our first issue, and consider him or her as a part of your family. If you treat your patient like that, you will not do much mistake as we already do. So you deliver the best quality of service to him or her. Rule number 3, we don't treat figures and labs, but we are dealing with living patients. Beside being human, is also very fragile ones and suffering physically, psychologically, mentally, financially, socially, and lack knowledge and confidence. So be patient with your patient, appreciate them, be considering and empathetic, and before all, you should be professional, honest, and trustable. Rule number 4, do your best based on evidence. Do the right thing and share your patient in decision making, especially in critical situation. No, there is nothing called ignorant or illiterate patient, but there is busy doctors who lacks either time, experience, or is negligent. Rule number 6, we are not dialyzing our patient to keep them alive, but to maintain a good quality of life, which differ much, and help him to be productive as much as possible. Don't leave your patient waiting for this. بتحرك.
20 minutes.
2 minutes.
2 بجد ولا 2 اسكندراني برضه؟
لا 2 بجد.
طيب.
I have 2 remaining parts of the my talk.
Okay.
One is a small video. I got the idea yesterday. Actually, I'll show you. I left this unit 1.5 years ago, which was very hard to me actually. I called my nephew by phone yesterday, telling her go and take photos in reality, in a video, in reality, what have been done in this unit. I remember a statement said to me by one of the patients, telling that I have been dialyzed for all 7 years, through which it was very hard to me the night of dialysis. Today, I'm happy to go to the unit because I feel that it is a part of a club or a social meeting. I think we succeed to do that and change the mind of nurses and the mind of patients, which is very important. Patients suffered a lot because they know their rights and they are requesting for their rights. And after the video, you will see the video. I'm sorry, it is in Arabic. دي الوحدة بتاعتنا. هي الوحدة دلوقتي بقت 18 مكنة. All of them are 96 with full option. It is all charity. It is non-governmental and non-private unit. I'm proud in this unit that nurses are practicing this work without provision of others. They don't need now doctors. They wash their hands. They keep patients themselves keep washing their hands before dialysis, not because doctors telling them to do that, because they are accustomed to do that. We have 2 spare machines in the negative unit and in the C unit. We don't have B there for any emergency. الهيد نيرس بتاعت اليونت which is young but she is accepting the idea and dealing with it. Dalia is saying what she do in the unit.
كل حاجه بالنسبه للمريض متوقعه بشكل غير عادي. بس بركب المريض عادي بديله وقت مش مهم ان هو يجي بس مجرد ان هو بيغسل عشان يغسل يشيل بولينه ويشيل يمين ويمشي. اهم حاجه ان المريض يكون بيغسل علشان يبقى انسان طبيعي بقى يخرج من الغسيل. لازم يعيش حياه طبيعيه، يروح شغله، يعيش مع اولاده، يتفسح، يروح في اي مكان ابوه عايزه ان هو يخرج كويس، يخرج اكله مظبوط، كل حاجه بالنسبه له مظبوطه. بعد ما اخلص الغسيل طبعا مهم جدا ان انا لازم امسح معاهم كويس جدا مش علينا اي فقر دم او اي حاجه عشان خاطر المريض اللي هيركب بعدي.
I'm sorry, it is in Arabic, but actually nurses and patients are aware. They are dialyzing the patient not to maintain their lives, but to keep them living at their best way. How many of the audience know about the non-diffusion time? 1. Patient there know the right, know and ask for non-diffusion time. Over the 6 years where I were in this unit, we have 60 patients over 2 shifts, hemoglobin ranging from 10 to 12, only 2 cases of catheter-related infection reported over 6 years. PTH acceptable range except in 3 patients, one of them did parathyroidectomy, and the 3 patients have been dialyzing since 14, 11, and 10 years respectively. Most patients are working if we continue the video, it has part with the patients. Some of them leave the unit after dialysis, go to their work. They don't interrupt their life. And even those who cannot work, actually, we brought volunteers who taught them to do simple works like crochet, like necklace and whatever, and they sold their work and earned money from it. Actually, I think it is an ideal unit. I love it much, and I think I did something. Conclusion, together we can do the change. It is not my work, it is the teamwork, actually. To conclude, it is never an accident. It is always the result of high intention, sincere effort, intelligent direction, and skillful execution. It represents the wise choice of many alternatives. If you want quality, act as if you are already have. Quality question create quality, a quality life. Successful people ask better questions, and as a result, they get better answers. Quality health system lead to patient safety and public satisfaction. And at last, I will end by this nice word: dreams is not what you see in sleep, but it is the thing which does not let you sleep. My last part in the talk is two announcements. One, Dr. Mohammed Nasrallah will tell, and the other, actually, it is encouraged by Dr. Majid al-Nahas. He challenged us on the OLA. As a great size, I actually recommend all of you to join. It was about the World Kidney Day. We are doing now in Alex an enlarging program to educate the patient and to screen for CKD over a large number of patients. Many of colleagues will share with us, and we will publish, inshallah, the result on the OLA. Thank you.